All right. So welcome back, everyone. So this is our first grand rounds of the 2024-25 academic year. So excited to be back in person, to see you all here. We have a great program for the whole year. Hopefully you've received that by email. And then, make sure to mark your calendar for those in-person sessions that you'll be at. Today, we have the honor of a very special visiting professor. So Dr. Hecht from New York, and for an introduction, I'll turn it over to Dr. Tay.
Thank you so much, Drew. I'm glad the residents didn't take him out too late last night, but I heard that y'all had a great time. So I want to introduce Andrew Hecht. Andy has been a good friend for well over 20 plus years to many of us and on the spine service. And he has done his medical school training as well as his residency at Harvard and did his spine fellowship at Emory. After that, he went over to New York and was at Mount Sinai and has been there for the last 25 years or so. And over there has accomplished multiple things. And if you read his CV, I could spend entire grand rounds going over his CV, but the salient parts of his credentialing for us is that he is the spine consultant for the New York Jets, the New York Islanders, the New York Dragons, and some of the collegiate teams in New York as well. He serves on the NFL Brain and Spine Injury Committee, as well as he's the AOS representative for the Inter-Association Task Force for Spine Injuries in Athletes, which, as you may know, if you do your play safe, it kind of determines what the rules are for removing helmets, face masks, pads, how to manage an spinal injured athlete on the field. He's part of multiple committees for the Cervical Spine Research Society. And as a plug, I want you to go and see his YouTube video on cervical spine research. So he's going to talk about cervical spine injuries in the athlete, the state of the art. And welcome, Andy. Thank you so much.
Thanks, Bobby and Sig and Ben and everyone here for inviting me to come. It's been always great to catch up with old friends and come out. I really enjoyed your case conference yesterday, and going out to dinner with the residents last night was really a lot of fun to get to see you guys in that informal way and see what an incredible group of residents you guys have here and the esprit de corps amongst the faculty and the residents. So they asked me to come here and talk about cervical spine injuries in athletes. And this is a talk not for spine surgeons only. This is a talk for everyone who takes care of athletes at any level, whether it's high school, pee-wee football, college, or professional sports. And these are my disclosures. Many years ago, I pitched this idea to the academy that most people know nothing about how to do this other than about how to make decisions about spine injuries in athletes. And that is, we put together the world's experts on these injuries, not just it's not a technical, how do I do surgery book, but it's a how do I make decisions book. For example, how many in this room know how to take off a football helmet? Right? How many know how to take off a face mask? Right? How many know what to do when you're covering a hockey game and someone's down in the corner and you have to deal with that? So this was a very practical book. How many know when someone can go back to play with various injuries? So we assembled these experts, and I got you guys for the residents in the program. This should be coming today or tomorrow. I got you guys all copies of this book. So in the book itself, there's video and stuff, and you'll see the salient chapters, but it's very helpful to any of you who are taking care of athletes in a practical way. So I think you'll enjoy it. So a lot of attention. Anybody know who Kevin Everett was?
September 9th. The second half of the game against
this is
the Broncos.
Broncos versus the Bills.
Do you remember what was going through your mind?
Going down, nobody blocking me. I just saw the ball carrier and went straight to him. Just the time of the things were bad. And I was in shock.
That head-to-head contact right there. Kevin Everett sustained a spinal cord injury.
I never thought it would happen, but it did.
And that's what you often hear. You get these cases, it happens every few years. And then you always hear the story that I never thought it would happen to me, but it does. And Kevin Everett just brought a lot of attention because he had something called thermal cooling. If you remember this story, where he had systemic cooling and he made this dramatic recovery. I'm going to come back to that later, but this really brought renewed attention to spine injuries in athletes. And at the league level, and the NFL level, it's like, what are we doing? Are we prepared for things like this? So today's talk is going to talk about the management strategies for these different problems. It's also going to talk about return to play guidelines, some of the common injuries that you see that cause great consternation on the field, as well as even when you're back in the office trying to evaluate these things. As you know, we keep track of these injuries. There's a national spinal cord injury registry, and sports-related spinal cord injuries is fourth on that list. And most of these injuries are cervical rather than thoracolumbar. And these happen every year across this country. And there's a database, and I hate slides like this, but just to make the point that it's not just football, gymnastics, hockey, lacrosse, wrestling, cheerleading. There's reported incidents of these types of injuries. Obviously, football and rugby have been a big part of it. When you're taking care of a collegiate team, high school team, professional team, you want to have a plan when you do this. You don't want to be, all right, call 911, get the ambulance here, we got to do something. You want to have an organized plan, even if it's a high school game. You're covering a high school football game, which many of you may do at some point in your life. You want to know what happens if something goes sideways and you're covering that game, because it's not always going to be a knee or a shoulder or an ankle that you're going to be dealing with. What are you going to do when there's a kid laying motionless on the field? What are you going to do? So it's best to have a well-practiced team-based approach for this. I can tell you every year in July, I have to go to Jets Complex. We do this whole rehearsal. I'm telling you, it's like simulation with dummies. And even, you know who Damar Hamlin is? Anybody know who that guy is? So after that, it turned into even another level. Not only were we rehearsing concussions and spine injuries and how to take a face mask off and put people on a board. Now they're working on things like, all right, I have a cardiac arrest, or I have one of these other things. I have commotio cordis. What am I going to do? So, and having this plan is very important, especially if you're taking care of even more high profile teams. You don't want to be doing something on the field and not have a plan. So that's what the emergency action plan. One of the things when you're taking care of athletes is understanding the mechanics of the game that you're playing. What are the high risk behaviors and how to avoid them? So one of the big problems is that we don't have a reliable predictor of risk of permanent neurologic injury. Now, football has been the great laboratory of spine injuries in athletes, especially the cervical spine. Rugby is right there. It's a associated cousin. And, you know, Joe Torg, we know Joe Torg from the University of Pennsylvania. You read about the Torg ratio, but Joe Torg was a surgeon at University of Pennsylvania, and he set up a database. And this goes back into the 70s. And he tracked over a 20-year period cervical spine injuries. And he collected data from physicians, coaches, trainers, administrators, what have you. And to be in this database, you had to be hospitalized for 72 hours. And if you had a fracture, a subluxation, a dislocation, a brain bleed, you're quadriplegic or died, you made it in. So what they saw when they collected this data was a decrease in the number of brain bleeds, but an increase in the number of cervical spine injuries. What happened? There was a tremendous surge in cervical spine injuries and fractures. But what happened? The helmet came. And with the helmet came protection of the brain, but people were tackling with their head down, head first tackling. And the modern helmet changed the game dramatically over that period of time. So the NCAA in the mid-70s banned this concept of using your helmet, the crown on top of your helmet, like a weapon, almost intentionally tackling someone that way. And that we define that as spearing. And this is a big deal. And we talk about it every year and across this country. where no player shall deliberately use the helmet to ram an opponent. So what is spearing? This is spearing. So this is a game between the Packers and the Bears. That's spearing, where a player, you see the mouth guard goes flying out. That's Devontae Adams when he was on the Packers. And, you know, you look at it, you watch it on TV, they're showing it from every angle. It's like, it's really pretty spectacular. That's Aaron Rodgers. And you can see there, the mouth guard goes out. Now you see the hands waving. Whenever you see the game, the hands waving, you know something dramatic has happened. And he's boarded. Unfortunately, he woke up. He had a bad concussion, and he woke up from that. So it's a big deal, that prevention. So when they started to change behavior by banning spearing, we saw a dramatic change in the rate of these injuries. The numbers of fractures, dislocations, subluxations dramatically went down. 70% in high school, 65% in college. But then 15 years later, we saw a trend that was going the wrong way. Started going back up again. So Torg partnered with then Eagles coach Dick Vermeil. I mean, I don't know if you guys remember who this is. This is a famous NFL football coach. And they made this video. Don't prevent paralysis, don't hit with your head. You'll hear this play heads up football all the time now. It's everywhere. So this axial loading with head down contact has really been the primary cause for these catastrophic spine injuries. And you'll see these flyers everywhere. There'll be you go to a high school game, even Pee Wee football, they're emphasizing this technique. This has been a national movement. Even the NFL supports this entirely. And they saw, again, when they did that, the injury rate went right back down. So we're going to talk now about some of the common things that we see when taking care of athletes. Now, if you go, and we're going to talk about burners and stingers, we're going to talk about cord neuropraxias, we're going to talk about teardrop fractures, then we're going to talk about some of the common things like disc herniations that we see in athletes and how to deal with them. So if you go into an NFL locker room and you say, how many of you have had a burner? You're going to see like 70% of the hands, 60% of the hands go up. How many of you guys ever have a stinger? Anybody in this room ever have a stinger? So you know what this is like. And it's very important to understand this. And this is where people get confused. A stinger or burner is unilateral in one arm only. It's not in two arms. I always try to trick players when I'm talking to them. I'll say, you know, have you ever had a stinger in both arms at the same time? I use that word. And they'll say, yeah, you know, I've had that before. And I'll come back to that, but that's not a stinger. If you have it in both arms at the same time, not a stinger. You have it in an arm and a leg, not a stinger. It's very important when you're covering in the heat of the moment, you're on a field, you're a sports medicine, orthopedic surgeon or team doctor, and you're saying, hey, did you have it in somewhere else? It's a very important question. I even see this at the combine when I see players getting evaluated. And when I see a sports medicine doctor write in the history of the player, he had a bilateral stinger, I literally can't believe it. Okay, so it's very important to distinguish between a stinger and a cord neuropraxia. We'll come back to that, but it's a very common thing. Typically, the athlete says, you know, I got numbness in my arm or some pain. It's usually upper trunk kind of stuff or root problems of 5 and 6. These symptoms can last for a few seconds. It can go on for weeks. So the burner syndrome, we thought about, this got a lot of attention. And really, when Joe Torg came up with his ratio, they saw that athletes who have a little congenital stenosis were much more likely to get a stinger. Then they took it even a little further. We wrote this paper looking at the mean subaxial cervical space, which is the disc level sagittal diameter of the canal minus the sagittal diameter of the spinal cord. And this is just predicting athletes at risk for stinger. It's very specific. Okay. So the point of this was not that you can't play, but it's often helpful to predict who's going to have a stinger. So when can you go back to play when you have a stinger? When you're asymptomatic. What does that mean? You're asymptomatic, sensory, no pain, no numbness. You have normal strength, and you have full painless range of motion. And remember, just because you had a lot of stingers is not a predictor of a serious spinal cord injury. What about cord neuropraxia? This is where the athlete experiences an acute transient neurologic episode and is felt to be of cord origin. And what are the patterns of involvement? It could be both arms, both legs, an arm and a leg, what have you. I can't tell you how many times I've seen this. We had a player recently for the Jets who had, in training camp, had an injury, unconscious, brought to a local hospital, woke up, came in to see me, later that week. And after talking to him, and he's telling me about how he had symptoms in both arms and one leg. And I said, have you ever had this before? He goes, like, what do you mean? Have you had stingers before? He goes, oh my God, how many? It goes, have you ever had a stinger in both arms? Yeah, like 10 or 11 times. This is a young man who escaped through high school, college, through the combine, and had probably 10 cord neuropraxias. We retired him that day. And by the way, the sense of relief that I think this young guy had from having had all these was profound. So you may be the person who picks this up. And this is modern day stuff. So if you don't ask them, you'll never know. So when I evaluate them, I go back, let's go back to high school. Let's go back to college. And we go through them and they always remember. When you have a neurologic episode playing sports, you remember. So these are the kinds of symptoms that you get: the burning, the numbness, the tingling. Sometimes you get weakness. These usually resolve. You can resolve in seconds to minutes, or they go on for days. And the longer episodes usually have a more gradual resolution. And by definition, you have to have a complete return of normal neurologic function, pain-free range of motion. So Torg continued this evaluation, and he published this very important paper in the 80s looking at neuropraxia of the cervical spine with transient quadriplegia. And he postulated a link to the developmental narrowing of the canal. You could see developmental narrowing of the canal on this X-ray. As the spinal laminar line approaches the posterior border of the lateral mass, when this distance comes together, you can see that's somebody who's got congenital cervical stenosis, even without an MRI or calculating fancy numbers. He identified this imaging marker called the Torg ratio, which was basically dividing the spinal canal diameter over the vertebral body diameter, and it was felt to be pathologic less than 0.8. So he did a big study, and he looked at various groups, one being asymptomatic college football players, asymptomatic professional football players, high school athletes, college athletes, and pro athletes who had at least an episode of a cord neuropraxia. Then he looked at a group of quads. These were football players who got injured and who were quadriplegic. And then he looked at some non-athletes. And if you look at this is the cord neuropraxia and developmental narrowing, looking at canal width. The cord neuropraxia is that green bar at the bottom, but look where the quads are. They're up there with everyone else. When you looked at the vertebral body size, the non-athletes tended to have the smallest vertebral bodies, but the quads had an intermediate sized vertebral body. When they looked at the Torg ratios itself, the biggest Torg ratio was in the non-athlete group, but guess who was second? The quads. And the cord neuropraxia group was down at the bottom. So the ratio is very sensitive, but very non-specific. So it's not a great screening test. So just because you have a developmental narrowing of the canal doesn't preclude you from participating. And I'll see this, you go to the NFL combine, and if you look at them the wrong way, they'll get you an MRI at the combine. Anybody ever been to the combine? Or it's one guy. Okay. So they will get MRIs, X-rays, CT scans right there. And read right there. And even with the most minor complaint. Why? Because they're trying to make sure they're not setting someone up to come to this level of participation who is at risk of getting hurt or have a serious problem. And I can't tell you how many times things have been picked up at the combine that have been missed completely before and never been picked up before, that precluded someone from playing. So what's interesting about this study is that none of the quadriplegics ever had cord neuropraxia. So none of these had a warning shot that sort of heralded before their quadriplegic event. And then they looked at these 45 athletes who had a cord neuropraxia who returned, and none of them had a permanent neurologic injury. So he went further. He said, let's go further. Let's look at these cord neuropraxia patients, the witnessed cord neuropraxias, and follow them over time. Let's see what happens to them. And these all had developmental narrowing of the canal. They had the average torg ratio in this group was 0.68. They all had developmental narrowing. Interestingly, they all had disc level canal diameters of 10.1. So over half of them returned to contact sports. And the group was not different by their age, sex, type of sport, the type of cord neuropraxia they had, what have you. Half of them had another one. And look at this. Who's going to let someone go back and have 25 cord neuropraxias? But that was the range in this study. So the risk of developing another cord neuropraxia was higher in contact sports than in other sports. All radiographic measurements, with the exception of actual cord diameter, were predictors of risk of recurrence. So here it is. The bigger your canal, the less likely you are to return. The more likely you are to return. And the smaller your canal, the much more likely you are to have another cord neuropraxia. So they followed these people up for years, and nobody who went back had a permanent neurologic injury secondary to contact sports. So cord neuropraxia, the way you should think about it is as follows. There's different groups. You have the cord neuropraxia, you have the developmental narrowing of the canal group. You have the totally normal canal group. And the third group is the group that had a cord neuropraxia secondary to a new lesion, like a disc herniation. If you're in the non-stenotic group, you don't have congenital stenosis, you have a normal canal, you could have a few more cord neuropraxias. There are some people, we don't know why they're having them. They have perfectly patent canals, and they'll have a bunch of these, and once they become fully neurologically normal, we'll let you go back. But there may be something about them that after 5 or 6 of these, they're going to drop out. The ones we worry about that's much more common are the other two groups. First is the developmental narrowing of the canal. We'll let you have 1 or 2 of those. That's it. And then we'll retire you. We don't want to do the thought experiment of letting you go back over and over again. It just seems like a common sense bad idea to let you do that. And then there's the third group, which you're going to come across, which is, okay, I had a cord neuropraxia, now I have a disc herniation. That has to be fixed, even if they become asymptomatic. So if you have an athlete who's got a big disc herniation, who had a cord neuropraxia, who becomes asymptomatic, you can't go back to play again. That's got to be fixed before they go back. So patients without any instability, they can return without risk of permanent neurologic injury. I always tell the players there's a 50% chance it's going to happen again, especially in the developmental canals. And it's can be predicted on plain film imaging, and it's correlated with the relative amount of canal narrowing. Now, you'll read about this in your books called spear tackler spine. This is an absolute contraindication to playing, which is you often have a developmentally narrow canal and you have loss of lordosis and you behave badly. You keep spearing all the time. And believe me, there are collegiate and high school players who do this all the time. You just saw at the NFL level, like the definition of spearing. So this is an absolute contraindication. We have started getting this loss of lordosis, this neutral spine, bad technique. What's so important about lordosis? It allows you to dissipate the load in the muscles around the spine. Once you lose that, the spine becomes a segmented column. And this is a problem because you've lost that lordotic shock absorbing force. And now the spine starts to compress and you get disaster. And that disaster is the teardrop fracture, which is a very common injury in football and players and rugby players, which is a 3-part, 2-plane fracture from axial loading and flexion. So this is a case when I was a fellow, a football player in Georgia, 3-column injury, incomplete quadriplegia. Okay. So this is a devastating injury, and all from witnessed head down tackling, head to head contact. There it is. And they look pretty benign. They have this little fragment, the teardrop. You can see that little piece. You say, that can't be so bad. It's a disaster. And you have to differentiate it from the compression fracture, which you will see at times as well. So what about managing these things? We focus on what are you going to do on game day, how you're going to transport these people, and how you do a good workup. And this starts with pre-game planning, working with understanding your protocol and working hand in glove with the athletic training staff. And I can't tell you how the relationship you have with the athletic training staff is critical. They are there every day with the players, especially at the professional level. And you have to have a real open line of communication. You want to make sure if you're covering a game, whether it's a high school game or college game, that you have all the relevant tools. You have the backboards, the collars, the face mask. What are you going to do? How can you get the face mask off if you have to do something? You want to know what hospital you're bringing them to. You want to know the local EMS who's around, and you want to understand the unique aspects of the sport. And a lot of times, these helmets, they change sometimes. The face masks change. And I mean, if we put these down here, watching you guys taking these face masks off, you may struggle for the first time you do it. That's why we practice it, because you're not doing it all the time. So what do? Player's conscious, ambulating, and has pain. You're going to escort them to the bench. You're going to ask them about symptoms. You're going to do a quick exam. You're going to ask them about the sensory motor symptoms they're having, if their symptoms are resolved. Do you have any weakness, pain, what have you? But this is the one where this is the hand waving scenario where the player is down on the field. And you get the hand wave from the players or the athletic trainer. You run out. And it's critical. You're trying to identify a cervical spine injury before you remove the player from the field. And this has been correlated with a better prognosis, because the goal is to try to minimize the secondary injury from an already traumatized spine. So when you have a face down player, you want to rehearse this. Now, you're so good at doing this in the operating room, but you want to be good about doing this on the field, even when there's 50,000 people screaming in the background. So you're trying to assume that you're assessing the potential for an unstable spine. And anyone who's unconscious on the field, you need to make sure that you assume that this player has an unstable spine until proven otherwise. These are some of the red flags of injury. Anybody who's got neurologic symptoms or any pain whatsoever, any deformity or any fear of moving the head, you're going to do your best exam possible. This is like a fantasy world exam because it's not practical to do this in the field, but you really want to get as good a neurologic exam as you can and having the patient do active range of motion. So this is a great case sent to me by the head athletic trainer from University of Georgia. So this was a 22-year-old college running back who's also a kick return defensive back who had a helmet-to-helmet contact during kickoff. Obviously you spend a lot of time seeing how the rules of kickoff have changed in the NFL. This is why. So they had a helmet-to-helmet contact. He's a very important player on the team. He had he was complaining of neck pain and stiffness, no neurologic symptoms. He's a very important player. The coach is like, we got to get him back on the field. Wait a minute. They took him into the tunnel and they got an x-ray. A lot of the big schools have the ability to do that. And this is what they found, this subluxation in the cervical spine. And here it is, disaster waiting to happen. So a fracture subluxation of the cervical spine with a traumatic disc herniation. And when they picked it up, he had pain. He was fearful of moving his head. He said, but he wanted to go back in. And the coach wants him to go back in. You, the sports medicine physician, have to make this call with the athletic trainer not to let this person go back. So what about the helmeted player? It may be, a lot of times you're not going to pull the helmet off, but maybe you're going to disassemble the face mask. And when players come to me at Sinai on game day, Usually they come, the helmet is still on, the face mask is off, because no one's better at removing the face mask than you. You're going to be much better than us at removing it when you get to a hospital. So if your suspicion is high, leave the helmet in place, because that keeps the spine in a neutral alignment. And we had this big meeting talking about this down in Florida, and it's better, you want to immobilize the head and neck in a neutral position. And if you take the helmet away, it's a problem. What about hypothermia? We talked about Kevin Everett, who's on the cover of Sports Illustrated. So in Buffalo, they gave him thermal cooling. What is that? The lowering of the body temperature for medical benefit. Bringing it down from 37 degrees to the 32 to 34 degrees. This hypothermia is divided. You can do different degrees of hypothermia. There's also systemic hypothermia and region and sort of local application of hypothermia. And because of Kevin Everett, there's a lot of interest in this. And they've been using hypothermia in the cardiac field for quite a while. The goal of therapeutic hypothermia was felt to be, you have this primary injury to minimize the secondary injury of edema, ischemia, inflammation. This paper on Kevin Everett was published in Spine in 2010. And they showed he had the C3-4 fracture, subluxation, traumatic disc herniation, but he probably had an incomplete injury when they really went back and looked at this. And they really didn't, and when they went back to look at this in real detail, he really did have an incomplete lesion, and wasn't a complete miracle that he had a complete lesion and return function. So where are we now with hypothermia? There's a big AANS, CNS joint section disorders of the spine, and there's felt to be not enough evidence to recommend for or against systemic hypothermia. And there are other complications of hypothermia, especially in the head injury population, before you consider this. So what do we do at the league level? Most of us don't do it. I think there are 2 teams out of 32 that use hypothermia. Buffalo does it. I think Miami does it. And I don't think anyone else does it. There's a lot of research going on about this. The story is going to continue to unfold. There was many years ago, we talked about this a little bit at conference yesterday, about that Dennis Bird with using other modalities like GM1 ganglioside. So what happened was when he had such a good result from his incomplete spinal cord injury and started walking again, it was heresy not to give people this drug. And then after lots of studies, felt it does nothing, absolutely nothing. The point was that incomplete spinal cord injuries, the jury's out for recovery. You can make a full recovery or close to, but for completes, it's much more unknown. So this story will you'll continue to hear about this over time, but right now, it's for most of the teams in the league is on hold. What about steroids? Remember, you're taking care of a young elite athlete in top physical condition. This is not a rollover MVA on your big interstate highway here, who has a spleen lac, pulmonary contusions, all sorts of other intestinal bowel injuries. This is not that. So this is usually an isolated injury. So what role does it have? What do? We emphasize, let's get your mean blood pressure up right away. I want maps of 90, 85, 95 up. And there's a big AO consortium looking at reanalysis of whether spinal cord injury steroids matter. And in that analysis, in that subgroup analysis, in this group of young people with an isolated injury, there's evidence that it benefits. So I think almost every single team uses steroids. So who could return to play? Obviously, you have a stinger, and you can return once you're completely neurologically normal and you've confirmed that the symptoms are purely unilateral. You can't go back if you're weak, you have any numbness. No, I just have a little numbness still at the tip of my finger. Sorry. Remember, in the heat of the moment, you don't work for the team. You work for the athlete and the player, and to protect them from themselves, from everything else that's going on around them. Somebody has like an abnormal gait, what have you, anything suggestive of that, any loss of range of motion, fear, he can't go back. So Torg came up with these guidelines and recognized set them up in different categories: no contraindication, relative, and absolute contraindications. So obviously, you're going to see these Klippel-Feil kids, congenital conditions. They often picked up incidentally, like your C5 and your C6 are fused together, no problem. You have a spina bifida occulta, no problem. You have developmental narrowing of the canal, and you had a single episode of a neuropraxia, or maybe two, no problem. You have a disc herniation that was treated, that resorbed or was treated with ACDF, you can go back. So we did a big study looking at big meta-analysis, looking at the return to play in contact athletes. And we pulled the results from our patients and other patients, and you have about a 75% chance of going back. Remember, in studies that you see, it's not always the fact that you had maybe you had neck surgery and you didn't go back, but maybe you didn't go back because of that. Maybe you had a knee problem also, or some other orthopedic problem. That's why when these studies that you read that are published from press clippings online and pulled together, it's like an insane data analysis situation, because you're not always getting the full story. And I can tell you a lot of the literature that we have is based on things like that. So what about disc replacement? You know, anybody know who this is? This is Jack Eichel. Jack Eichel is a player for the Buffalo Sabres, had a herniated disc, had a cord neuropraxia. He traveled across this country. I mean, he probably has the Olympic record for pinions. And everyone said you need an ACDF because you're going back to a high contact sport. And he finally found someone to do it, and he had a disc replacement. So that opened up a whole can of worms. So is disc replacement superior to ACDF in this population? Are there advantages to doing a disc replacement versus an ACDF in a contact athlete? And what about some of the issues that these disc replacements create, like heterotopic ossification? And what does it really make a difference at all in adjacent segment degeneration? So we looked at the rate of heterotopic ossification following disc arthroplasty, and we also compared industry-funded to non-industry funded studies. And we found that we started looking at these. This is, as time goes on, the rate of heterotopic ossification increases. And we have different grades of heterotopic ossification, but look at these grade 3 and grade 4s. You think those are functioning normally? Is that recreating spine motion? Or is that like a bad fusion? Or is it really functioning like a pseudo in a lot of ways, pseudoarthrosis? But we found in the industry-funded studies much lower rates of this than in the non-industry funded studies. So I remember I was moderating a session on this at CSRS, and we had all these international paper presentations from different countries in Europe showing these amazing rates of HO. And that really got me thinking, like, why are we not talking about it in the United States, but in Europe, this hasn't been, they're not putting these in the way you would imagine if it was the cure-all thing for this. So then we presented it just last year at CSRS, looking at adjacent segment degeneration. And do we have a bias when looking at these, looking at industry funded and non-industry funded studies? And we looked at the long-term studies, looked at 10 years. And we looked at the ones with conflicts and no conflicts. And once we removed industry funded data from the pooled studies, there was no difference in adjacent segment degeneration at all. So what are we doing? You know, these are some of the studies. These are looking at this and basically showing no difference. If you look at this last column in the non-industry funded studies, no difference whatsoever in the adjacent segment disease. So we ask ourselves, what are we doing? These are young athletes. You're putting these in. Now, you know from your joint replacement literature that no joint lasts forever. Will this last them 60 years? We have no idea. We see, if you look at the FDA database of complications of disc replacement, it's scary. All you have to do is take a look at that, the reported events. Like, I can't remember ever in my career my ACDF graft extruding and having to go back, or these devices failing. And it's, why do I want to do that in a contact collision sport athlete? Forget you and I, weekend warriors. We like to play tennis or golf or what have you. Why are we doing this? And obviously, we're not doing enormous numbers of ACDFs and disc replacements across the country on professional athletes at the highest level, but I won't put it in an NFL player. I won't put it in. I do the Jets and Islanders. I will not do it. I'll fuse you. And I'll go through the whole conversation with you of why we won't do it. But if there's no difference in adjacent segment disease, why are we doing it? We don't know the answer. We are optimistic. We still do them, and people are willing to have them. But are you really offering them any advantage? So what about, back to these contraindications, what about healed fractures? Compression fracture, you could go back. You'll see these clay shovelers fractures, you know what those are? These spinous process fractures at C6 or C7, they can go back. But you have to be asymptomatic. I'll even let you go back if you haven't healed it, as long as you have full painless range of motion. What about these odontoid anomalies? When do you see these? You'll come into contact with this often with the Special Olympics. But some of these people will escape through a full career and show up at the combine and have an odontoid anomaly or some other problem like this. And that's where you have to enter into the situation. Clipple file lesion at the upper level, occiput to C1, C2, can't go back. We had an elite wide receiver in college, came to the combine. They thought he was going to be a first-round pick, didn't even get drafted. But got signed as a non-drafted free agent, never set foot on a field. What about cord neuropraxias? If you have a cord neuropraxia and you have any of these findings, ligamentous instability, cord edema, multiple occurrences, you're out. The spear tackler spine, that loss of lordosis, developmental narrowing, degenerative changes, bad behavior, you're out. Any atlantoaxial instability, atlanto-occipital fusions, out. And obviously, we've seen this ad nauseum in every textbook you've ever read about White and Punjabi's criteria for instability. If you have any of these, obviously, you're out. Healed fractures. If you have a burst fracture, things with malalignment, facets that are incongruous, or you have any residual symptoms, you can't play. So we looked at another paper. We wrote another paper looking at how good are we at making decisions. So I made these scenarios of things that I've seen over my career, and we sent them out to members of the CSRS. We said, how good are we at doing this? And we also asked you, like, what was your experience? What kind of you have with dealing with this? And we found that most surgeons, the more experienced you are, the more likely you were to send people back to a higher level of sport. When you're first doing this, you get a little anxious because you're making these tough decisions. You always err on the side of being sometimes too conservative. That's possible, by the way. And most surgeons we found were not really following the guidelines. There was another study of another group of patients looking at this. Again, only half the surgeons used the guidelines. But if you were a spine surgeon, you were much more likely to send the player back to a higher level of sport than you were if you were a sports medicine orthopedist. And I can tell you, having done this for 18 to 20 years, I work hand in glove with the sports medicine orthopedic surgeons. And we talk about everything about when we're drafting players, who's at risk, taking care of active players, and communicating. When you're going to work with a college team or a professional team, this is what they don't teach you. This is a job not just of being a good doctor, a good surgeon, but being an unbelievable communicator. Because when you see someone who comes in, we were talking about this a little bit last night at dinner. If I have an athlete who comes in, remember that player I talked to you about I had to retire, you got to make a lot of phone calls. You got to call the athletic trainer. You're going to have to call the team, the head team physician, orthopedic surgeon, the medical team physician. And you're going to have to call the patient, sometimes their family. And you're going to have to, do you know who the surrogate father or mother is? The agent. And you got to call that agent. And you got to explain it to them as clearly as possible. Because they care a lot about this player for many different reasons. And they're about to lose this player and they need to understand. But if you don't communicate, it's a lot of work, because you have to make all of these calls right then and there if you can, because the athlete's scared. Or let's say you're going to do surgery. You need to say, hey, this person has a traumatic disc herniation and they had a cord neuropraxia and they're going to need an ACDF or what have you. It's not the surgery. They don't want to hear about the details of the surgery. You got to get everybody in their life on board so they can understand. And when that happens, then the athlete who's been part of this whole team machine is a lot more comfortable with everything you're telling them. All right, thank you very much.
Thank you so much. And I think we do have some time for discussion and questions. We have a microphone, and if anybody wants to raise their hand, and Dr. Gindelberg.
Thank you very much. As a rather undereducated non-spine surgeon, I really appreciate that talk. It brought me up a lot, what's happening. It surprised me a little bit since I was a resident. Things haven't changed that much in terms of needing to get more education around this topic, and there was a strong push towards avoiding head collision in athletes for about a decade, and then it seems to have almost reversed. And I heard that the NFL was right behind it, pushing more dangerous products. So it was interesting to see that we're still doing the research. The question I have is, I don't really understand, when you talk about steroids after spinal cord injury, how much steroids and what kind of steroids?
This is methylprednisolone protocol. It's a standard protocol. We use exactly that protocol, the loading dose for 24 hours. And we use it because it makes a difference for this subgroup of people. The general surgeon, we had this big conference in Florida. We had, representation from everyone, from every person who's involved in trauma came together, and it got a little heated in this conference. It was done in Pensacola, Florida, at Jim Andrews' facility over there, and it was a very active discussion. And we had to explain to the general surgeons, this is not that rollover MVA kind of situation with spleens out, the lungs are damaged, maybe there's a bowel perforation or bowel injury. This is an otherwise healthy, incredibly fit human being who has an isolated injury. And when they looked at this in the stasis trial, they found it made a little bit of a difference. So the big things that I emphasize is blood pressure support and the steroids. That's what you could do. And getting people stabilized into the hospital. That's the best thing that you could do. Other questions?
Hi, David Gendelberg. First of all, thank you. This was an amazing talk. I actually have two quick questions. So you were talking about keeping the helmet on and putting them on the backboard after an injury to keep the patient in line. And we know that the adult backboards are designed to keep the patient in line. I would imagine that the helmet puts a bit of a flexion moment on the neck. And so I was wondering if there was a modified backboard, like a pediatric backboard that has like a recess to allow a bit more extension to keep the spine in line.
A lot of times they have pads on, so it keeps them out of that position. So when they have these big shoulder pads on, it balances out, to your point exactly. And that's why we leave the pads on. You take the face mask off, because watching emergency room doctors try to take the face mask off is not a good look. It's like watching somebody trying to open up a coconut. It's like insane. So you want to make sure that you could get practice of getting the face mask off in a non-traumatic way. And if you've seen, we were talking about a little bit about last night, these helmets change. And like when we could do this rehearsal, and every July, we'll have all these different helmet types. And so people are familiar. And a lot of the more protective helmets, the players don't want to wear because they're heavy. Now they have this weird, have you seen this thing they stick on top of the helmet to pad the helmet more? For 10 years, I sat on the NFL Brain and Spine Committee, and just came off not too long ago. But I sat there, it was 95% talking about concussion and 5% talking about cervical spine injuries. So for us as spine surgeons, we just want to keep people neutral, get them and learn how to do it. And whether you put them on a board or not a board, people go crazy. Which way do you lift them up? Do you roll them and slide the board on? It doesn't matter. Whatever you're comfortable doing is the best answer. the lift and slide or the roll, whatever you rehearse and get really good at is great. And then we also talk about where should you do this, right? Like, where do you do things? Should you do this right there on the field in front of 50,000 people, or do we need to get you off to the tunnel and start doing more things? It really depends. There was a case once where, remember arena football, where they weren't quite prepared. They don't have the same level. And we had a player die on the field from a high cervical injury, unprepared. So you really want to take a minute if you're going to do this and familiarize. Just listen, these are uncommon injuries. And you say, well, we'll do better next time. And the next time may not be for a while. So it's one of these things at the NFL level after Kevin Everett, everybody has an emergency action plan. Everybody. Every Division I school has an emergency action plan. So it's important. And when that happens, it's a very, a traumatic thing for not just for everyone. Fans are freaking out. You are expecting the team doctor is trying to stabilize this patient as best they can, and you, the spine surgeon, are waiting for them to bring them in. So having a protocol makes this go smoothly. And I can tell you, we've had, in the last 20 years, I've probably had 5 players brought on boards to me at Sinai. That's how uncommon it is, 5 players. And by the way, 4 of the 5 had no spine problem. They had a concussion, facial fracture, lacerations, but you didn't know it right away because they were unconscious. So be prepared. Being prepared for this takes the anxiety level from here to here.
My other question about the ACDF versus ADR. So I thought it was very interesting that when you take the sponsored studies out, that you didn't see any differences. But usually sponsored studies also have very tight surgical indications. Did the non-sponsored studies have just as tight of indications? And could that have been a confounding variable?
It's a good question. You do these looking at these large series, but most of them, remember, these are 1-level fusions. And we're simply looking at development of new adjacent segment disease. And we eliminated a lot of studies. We tried to get the longest follow-up studies, right? Because remember, you're doing these in young people. And in my attitude, I was very excited about disc replacement when I was doing them at first. I've become a little bit more cautious about doing them because if you don't have a difference in adjacent segment disease, why are we doing it? But the question is, that story needs to be told still. So that's why I think they're still doing it. But if you look how in Europe, these were adopted much sooner than here. And they're not surging the way we're doing it here. So we'll see. The story remains to be told.
Hi. So we do a lot of work on astronauts trying to look at their MRIs before they go to space to predict who's going to have an injury or a disc herniation when they come back. And it sounds like you're also looking at a lot of pre-existing risk factors, like in the combine. With that, like, what's the decision making? Is it at the clinician level, the team level, or is it at the NFL level? And like, how does that go into policy?
That's a really good question. So every year, for example, I'll get team physicians go to the combine, they come back, and the NFL maintains its own medical record. So we're not like getting Clemson's medical records to look at someone, okay? So you'll do an evaluation. And for those of you who've been to the combine, it's a divide and conquer approach where the team physicians divide up the players and they do history and physicals. And you've never seen so many imaging studies. Like, it's insane. And you'll see on their record, you sign up to a special NFL site. Everybody who's been at the combine, you click on their name and you will see history, medical history, orthopedic history. And, some of us are great at it. Some of us are not so great at it. And then you'll see imaging studies, and you've never seen so many imaging studies. So what I try to do, to your question, is for the spine part of it, I'm trying to assess, first of all, can they play? Is there a problem? And maybe every 2 or 3 years, there's a player who shouldn't even be drafted. I don't even know why they're playing at all. Like somebody with an occipital cervical fusion or has an odontoid agenesis or something crazy, they shouldn't be playing. And then we're trying to assess risk, meaning if this player goes, are they likely to get hurt? To your point. So over the years have formulated, I have like a high risk, moderate risk, low risk, no risk kind of classification. And I'll make comments like, for example, and it comes up not just in cervical spine, but in lumbar spine. Okay, you have a spondylolysis and you have some symptoms from it, or you had a disc herniation and you were drafted, you had surgery and you were drafted. Like, we have to modify if we're going to draft, if you're going to get drafted, what you're going to do, maybe similar to what you do with astronauts. But we're trying to assess, first and foremost, is this person at risk when they go to the NFL? Secondly is, if we draft that player, are they likely to get hurt? And if they get hurt, what's the implications of getting hurt? Is it a fixable, treatable problem, or is it career ending? That's what and then what we do is the players from this data is shared. We try to share the knowledge with other teams and their team. For the spine group, we're pretty good at sharing that information. Now, like, a couple of spine surgeons will go to the combine and try to, like, this is only recently in the last year or two, will go and try to offer their opinion. And sometimes, most of the time, it's very similar to ours, but at times we may not agree.
Hi, Andy. Thanks for the compelling talk. I spent 4 years heading the ball in college, and I feel like I got multiple mild concussions. And in the concussion world, soccer features large. I didn't see that you had soccer on your slide for the sports that are at risk. If they're not as high risk, is it that you spend so much of your time training to hit the ball with your head? And I know that the whole effort is prevention. Don't hit with your head. But do you think there's a benefit to educating the football players, because they are going to do it, on how to prepare themselves if they collide with their head?
It's we haven't seen a huge number. We see more concussions in soccer than we do spine injuries in soccer. So the concussion part of this, in the book that you guys are going to get, you're going to see some familiar names from this institution who contributed to that section about concussion. And you can see the kinds of things and questionnaires they give athletes regarding this and the things that you need to know about that. But we haven't seen a lot of spine injuries in soccer players as a rule, compared to the other more violent sports like hockey and football and rugby and gymnastics and things like that. So, we just did this huge Delphi analysis with Scott Zuckerman from Vanderbilt. We must have been 20, 25 surgeons on this thing, set out this survey. And when you see these surveys, you see how impractical these surveys are. They don't often, going down the rabbit hole of these scenarios that you may never see, but trying to get consensus about who could do what, and trying to answer these questions on not just collisions, high contact sports, but maybe low frequency collisions and non-contact sports. And can you let people go back to play and those kinds of things? But soccer hasn't been a problem as much from the spine world as more for the concussion.
Andrew, thank you again for adding evidence to an area that's characterized by variability. As I often say that the presence of variability is clear evidence of the absence of an evidence-based approach, and you brought some real consensus to our approach. Concussion is part of your mandate as part of the spine and head injury prevention task force. So to that end, can you just briefly, your talk was so practical, can you give us some guidelines on when people can return to sports after concussion?
So I've stayed out of the concussion swamp, because that's a radioactive wasteland that you're just going to get contaminated, and I've completely stayed out of it. So I defer this to, I don't even want to put a toe in there, because it's a disaster, and staying out of that for me. That's why we have, even at the games, for example, and we have non-affiliated neurotrauma specialists who stay on there, who independently come in and do the help with the concussion assessment. So at an NFL game, you have 2 sets of team doctors, and you have a posse of these independent neurotrauma consultants who are there. And then you have people up in the like the press area surveying the field, looking at this. Why? Because there's been cases, you can't even account for every possible eventuality. The star quarterback gets hit. He's wobbling. The athletic trainer, the team doctors all run out there. The backup quarterback heads in. They pull him off. The next play, another injury. No one's paying attention. So they're all focused on the guy who you just took off. So they have all of these things covered, but the concussion evaluation, I highly recommend deferring this as a spine surgeon to the non-spine surgeons and the neurotrauma specialists who cover this. Yeah.
All right. So I think
Yeah.
we'll wrap up there, but Dr. Heck, thank you so much for visiting. We will have case conference in this room. A lot of our attendees will leave. Our residents will stay and any interested faculty, but we'll kick that off and pictures.